All right, so tonight we're going to do case study 145 and case study 146 over bipolar and schizophrenia. So you get 2 for 1. Um, yeah, and if you have any questions, you always can just type them in the chat. And otherwise, here we go. So case study 145. This is the scenario. So you are the registered nurse case manager in an outpatient mental health clinic. ST is here today for her outpatient mental health appointment. She was diagnosed with bipolar type 2 2 years ago. So bipolar type 2, uh, what is that? What sets bipolar type 2 apart? Can you hear me? Carrot, can you hear me? Okay. Phoebe hears me. Okay. Okay. So what sets bipolar 2 apart from bipolar 1? So somebody said less severe. Less severe what? Correct. Yeah, so their mania is not as manic, right? So they have hypomania instead of like mania. So they can still act with like elevated mood, but it's not so severe that they need to be hospitalized, right? Okay, so she's got type 2. She's been stable for the past year. Her last episode was one of mania that required hospitalization. Maybe it was really bad hypomania. Okay. ST is 29, married, 2 kids, age 2 and 4. She reports that her mood is better than it has been in a long time, and she has lots of energy. Does that raise any flags for us? So we're going to pay attention, right? When asked whether she thinks this is a recurrence of her mania, she says no. She just thinks that things are finally getting better. All right, so we're going to do some investigation here. It's common for patients with bipolar illness to deny the onset of mania because it feels good. What other information would be important to ask ST? So how are we going to piece out if she's actually got some mania? Like, yeah, sleep. What question about sleep? Yeah, are you getting any sleep? Not because of the 2-year-old, right? Um, yeah, so are you sleeping? How many hours are you sleeping at night? What else? Has she been taking her meds, right? What else? What are we going to ask her? So yeah, has she been eating, right? What are we going to ask about her thoughts? Right. Are they racing? Do they feel like they're just kind of on a train that you can't get to slow down kind of a thing? What about activity? Mm-hmm. Very good. And then something else that you can do is ask her if anybody else has mentioned anything about her behavior. Like, has anybody noticed that she's acting strangely? Because do they have the insight necessarily of their own activity as being abnormal? Correct. So correct. So has anybody mentioned anything about how she's been acting? Because that might be a good strategy for her. Is if people are saying something about her behavior, maybe that could be like a check for her. Does that make sense? Okay. And then number 2, what other information would help determine whether ST is experiencing the onset of manic or hypomanic episode? So remember, she is married, so might her husband have some insight into this? Because that's one of like the main things, right? Is that the mania can have negative impacts on their relationships. Well, the depression can too, right? So they would definitely be somebody that could give you an evaluation of how she's been acting. What about like when you, so we used to call it the across the room assessment. If you see her across the room, what could you look at to help you determine if she's manic or not? Correct? So like all the nonverbals, right? Is she pacing? Is she, hyperactive? Is she like darting her eyes around? Those kind of things. Correct. Along, you guys were talking about eating and sleeping. Something we could do is have her keep a food diary. Yeah, they could for sure. And that like outrageous dress, remember? They can like dress really obnoxiously and then they don't have time to eat. So we could have her keep a food diary, just journaling, what she's eating within a 24-hour period. Same thing with the sleep diary. How many hours of sleep is she getting at night? All right, let's go on to number 3. Bipolar disorder is a disorder of mood characterized by episodes of depression, mania, or hypomania. What symptoms might you see? Well, we've already talked about this. I feel like these are the same questions. Um, okay, so if she is manic, we talked about her, um, let's see. So I guess signs and symptoms of mania. So what about her self-esteem? What do you think it would be like if she was manic? Mm-hmm. What about her speech? What kind of speech things can you have when you're experiencing mania? There's some like terms that we use. Yeah, clang association. What else? What is it when you like just can't get the words out fast enough? They're coming so fast you just can't get them all out. Yeah, word salad is like a jumble, right? Yeah, pressured speech is that like I just can't speak fast enough to get all my thoughts out. Um, what about when you jump from one topic to another? Yeah, there you go. Flood of ideas. That's what I was getting at. Mm-hmm. Jump from one topic to another. Perfect. What about if in like the milieu, if your milieu is like loud and there's a lot going on, think like a restaurant, like a busy restaurant. How is that going to affect them? Yeah, wouldn't be good, right? Do they have an ability to filter? Mm-mm. They'd be distracted by everything. Um, Mood-wise, they can be agitated, moody, irritable, or super excited. What about activities? What kind of activities do they engage in that are not necessarily good for them? Mm-hmm. Right. Hello, Amazon. Mm-hmm. Can you imagine, like, 20 years ago, before we had like online shopping, you had to like go to a place? No, you're totally fine, Carrot. You had to like go to a place to buy things. Now, like, you can literally sit in your house and buy just about anything and get it delivered to your house. So I can only imagine like trying to keep this under control these days. I want this and that and this and that. Um, they also engage in high risk behaviors, utilizing drugs and alcohol, promiscuous sexual encounters, excessive spending, those kinds of things. So we talked a little bit already about how hypomania is different from mania, right? So what's the big difference between hypomania and mania? It has to do with the impact on your ability to do stuff, right? Mm-hmm. Which one are you still able to function? Yeah. So hypomania, you could still engage in like life activities. It's not going to significantly impair your ability to go to work or have social interactions. Um, and it also doesn't have any psychosis. But it is a change in behavior that's not normal for the person, and people would be able to tell. Um, on the other hand, mania is significant impairment of the ability to like interact in social situations, occupational settings, like school settings. The mood is so elevated, it's just super unstable. And so, to get people back under control when they're experiencing these manic episodes, they have to be almost always hospitalized to keep them safe until we can get them stable. So, people always get confused thinking hypomania is somehow like depression, but it's not, right? It's just less severe mania. So, it's like chilled out mania. Make sense? Of course, y'all know because y'all here. Y'all paying attention. Tell your friends. Okay. Y'all aren't going to miss that on the test, are you? No, you're going to get it right because we show up. All right. Number 5. So lithium is a mood stabilizer commonly used to treat bipolar. ST has been taking lithium for a year. When she started her initial lithium dose, she would have been cautioned to report side effects. Which are the common side effects of lithium? Select all that apply. So just a side note about select all that apply. Don't be afraid to pick all of the correct answers. Sometimes you guys are guilty of leaving correct answers on the table. So don't think that you have to like pick 2 out of the 5, because sometimes all 5 are correct, or 4 out of the 5 are correct. So don't be afraid. I know that select all that apply are intimidating, but try not to let it get in your head. Okay. Okay. So is thirst? Is thirst a symptom, uh, a common side effect of lithium? Yes or no? We're going with yes? I have a no. No. It's actually yes. Thirst is a common side effect of lithium. What about nausea? Mm-hmm. Tremor. Mm-hmm. What about dizziness or constipation? So I have no on dizziness and constipation. Well, they're dose related. If your lithium levels are within normal limits, you shouldn't have side effects. It's got a really, lithium has a really narrow therapeutic range. So how do we monitor that? What do we do to check lithium levels? Yeah, it's a lab test. Hmm. Okay, so toxicity can occur with patients taking lithium. If there's ever any kind of medication who's got some kind of like particular side effect, You need to know it. Okay. So dizziness and constipation I have are not correct. But if you guys, this is not going to be a question on your test, but just make sure that you are familiar with side effects of lithium. Mostly because we want you to know what the signs of toxicity of lithium are. So that is something that you need to know is signs of lithium toxicity. Um, so number 6, what are the signs of early lithium toxicity? Select all that apply. So is dyspnea a sign of lithium toxicity? Lethargy is one, you're correct. So dyspnea is not. What about diarrhea? Diarrhea is, yes. Lethargy, yes. What about vomiting? Right. And it doesn't make sense for insomnia to be true if lethargy is true. Does that make sense? So insomnia is not correct.
So I have a question about like just 5 and 6. So when it says like common side effects, we should just think about, I mean, obviously common ones, but ones that you don't necessarily need to report to the health
Correct.
provider. Okay.
Correct. So things that she shouldn't be freaked out if she has. But if they become too like problematic, they start really affecting her, then she needs to call the doctor or the provider.
Okay, thank you.
Mhm. Okay, early symptoms of lithium toxicity. So all of them are vomiting, diarrhea, lethargy, slurred speech, muscle weakness, and then this hand tremor. As your lithium levels rise, the hand tremor gets worse. Your GI upset gets worse. You start getting confused, uncoordinated. You can get really sedated. If you get really toxic, you can have seizures, circulatory failure, pulmonary complications, and death. So the patient education with lithium is really important. And it turns out her levels are good because you want them to be between 0.4 and 1.3. So you don't have to memorize the lithium levels. You just need to know what it would look like if somebody's toxic. That way you can give proper education. Okay, so we're going to skip 8 and 9. You guys can do those on your own. 10, you can also do that one on your own. What else do we use to treat bipolar? Let's do number 11. So you assess ST's understanding of her lithium drug treatment using the teach back technique. Identify the statement by ST revealing a need for further education. So A, I take my lithium tablets with meals. B, I need to be careful because lithium is addictive. C, I will call my doctor if I have severe vomiting or diarrhea. D, I will keep my appointments to have my drug levels checked. Which one reveals that she needs more education? So which one is wrong? There's just one answer. It is not addictive. That is correct. Okay. Number 12. Given her history of bipolar disorder type 2, what should you teach ST to minimize mood swings? So how are we going to, what kind of tools are we going to give her in her tool belt to help keep her bipolar in check? Take your meds. Yeah, be careful with smoking and drinking or any substance abuse, including like things like caffeine, right? Depending on how sensitive you are. Regular sleep schedule, yep. Yeah, if she's experiencing mania for sure, she doesn't need to like always be on a high calorie and protein diet. but just a healthy diet, right? What about stress? Keep it in check, right? And then what about appointments? Yeah, support system. So keeping appointments with the counselor, with the doctor, with support group, um, making sure you're going to group therapy or whatever it is that she's um, connected with to help keep her in balance. So ST is told that her lithium levels within normal limits. She states, I feel better than I felt in ages. She expresses hope that this will last a long time. All right, so I guess she was right this time. They tell her to avoid stressful situations, and she's got a 2 and 4-year-old. I mean, her life is like a stressful situation, right? My oldest two were that close, and it was people that, it's a whole thing. Okay, let's do the schizophrenia one. Everybody all right? Perfect. Okay, you're working in an inpatient psych unit. Perfect. I need to do an initial assessment of RB, who's been just admitted. He has a diagnosis of schizophrenia paranoid type. He's 22, has been attending the local university and living at home with his parents. RB has always been a good student and has been socially active. So, what do we think is going to happen to his standing in school and his social activity? Yep. hmm So, last semester, his grades began declining. There it is. He became very withdrawn and spends most of his time alone in his room. So, this is a significant change in his baseline, right? And he's in the age range, right? 22-year-old male. Isn't it like 15 to 25 or 18 to 25 or something like that is the range? Yeah. Um, blah, blah, blah. His personal self-care has deteriorated. Is that a sign? hmm As he can go days without bathing. Prior to admission, Arby spent several weeks in seclusion. Remember, he's paranoid, right? He refused to join family gatherings, isolated himself, and closed the blinds. Why did he close the blinds? Remember, all of these details are not wasted, right? Within the past 2 days, he refused to eat, saying they have contaminated the food. As you approach RB, you note that he appears to be talking to himself. When you talk to him, he looks around and answers in a whisper, but gives you little information. He states, they are watching me and told me not to cooperate. Those voices are never happy, friends. They are never happy and they never want to cooperate. Um, they're never telling you that you are a wonderful human being. They're never trying to build you up. They're always angry. Okay. 3 negative symptoms of schizophrenia that RB is experiencing. So what's a negative symptom? Oh, good. I'm glad that the sim lined up to this week. I got to do with one of the groups that's actually they're in the other 3 group. Um, and it was good fun and it was actually really helpful. So negative symptoms is something's missing, right? So things that you would expect somebody to have that they don't. So what negative symptoms is he experiencing? Yes. So remember they all start with A. So he doesn't want to be social. He doesn't want to do the things that he did before, right? Yes, not motivated. So remember they're like the what is it called? Um, yes, not having pleasure in things. What is it? Affect. That was what I was looking for. So like a flat affect, right? Alogia is that they don't speak. Avolition, they don't have motivation. Socially withdrawn, asocial. Poor grooming, I don't know that that's starts with an A, but they stop like doing self-care, right? And then that inability to experience pleasure, anhedonia. Positive symptoms that RB might be experiencing. So that's number 2. What are 2 positive symptoms? So remember, positive symptoms are additive. They're things that are added on that you wouldn't expect a normal person to experience. So what is his hallucination? So remember, what's the difference between a delusion and a hallucination? So remember, hallucinations are experienced with the senses, right? Hallucinations you can see, smell, hear, taste, feel. Delusions are false beliefs. Yeah, no, it's easy to do. So delusions are thoughts. Hallucinations are senses. So he's talking to somebody that's not there. So that is a hallucination, probably, right? Because he obviously sees somebody that he thinks is there. Somebody's trying to poison him, right? So delusion. Somebody are there watching me and told me not to cooperate, right? So he thinks that somebody's watching him and telling him not to cooperate. Yeah, so he's has altered reality, right? Bizarre behavior. Um, yeah. Moving on, number 3. Give the definition. Okay, so we're not going to do this. You can do this on your own, but this would be a good exercise, defining what these different types of delusions are. Okay. So grandeur, remember you think that you are super important, you have superpower, you're a celebrity, that kind of stuff. Persecutory is kind of like what our friend is experiencing here. He's being singled out. People are trying to harm him. He's being poisoned. Thought insertion is just like it sounds. People are putting thoughts into his head. Ideas of reference is that, like uh, stuff on the radio or newspaper articles or television broadcasts have like a secret meaning just for him. And then somatic delusions is that your body is changing in weird ways. So number 4, what symptoms indicate that RB has paranoid schizophrenia? So remember, let's see if we can go back. So what is the paranoid stuff? Food is poisoned, right? Yep. Mm-hmm. They're watching me. They can hear me. They told me not to cooperate. Correct. Talking to nobody that's actually there. Why is it important to know RB's history before he's diagnosed with schizophrenia? Ooh, this is a good one. Yeah, to see what his baseline was. What else? Yes. So what this question is getting at is there anything else that might appear to be schizophrenia that might not actually be schizophrenia? Mm-hmm. Mm-hmm. So other things can cause psychotic symptoms, okay? It doesn't have to just be schizophrenia. So drug use is definitely one. We had this period of time where people were getting really bad K2. You guys know what that is? It's a drug, and it was making them act completely psychotic and just like out of control. It was a really huge problem. Um, They were being super violent and aggressive and just crazy. And it was the K2 that um, they were using that was causing that. Um, Alcohol withdrawal can cause hallucinations. Have you guys done the ETOH sim yet? The alcohol sim, alcohol withdrawal sim? The last one. Okay. So you go through a CWA scale, and that's a kind of helps you grade how bad withdrawal your patient is experiencing. And they can totally hallucinate. They can see things like climbing on the walls and all sorts of craziness. So yeah, alcohol withdrawal is gnarly. Diagnostic screening. So, like you guys were talking about, we need to know family history, um, do maybe one of those mental status exams like you guys did in your sim class. We want to do CBC, CMP, urinalysis, drug screen, blood alcohol level, a full physical examination, try to get a picture of what's going on with them. Most important initial interventions. So, what is the most important thing that we need to do for not only our bipolar patients, but also our schizophrenic patients? Yes, keeping them safe. Remember, if they are having any delusions or hallucinations, especially hearing voices, the voices are usually not telling them to go and, pet puppy dogs and help old ladies cross the street, right? Um, they're usually telling them to, go run out in traffic or um, just horrible things about themselves, or that other people are saying horrible things about them. Um, so safety can be a really big thing. Remember, you did a suicide risk assessment as well in your sim because they are at high risk for suicidal and homicidal ideation. So it's really important to determine if they are struggling with that. That way we know how best to keep them safe. Um, Make sure that, or what else? When you're interacting with RB, what's something that you need to establish pretty quick with him, if at all possible, that you probably experienced during sim? Yes, right. Like, please, just for the love, take your medication. Um, is it easy to get somebody who is paranoid to take medication? It's a whole thing, right? Because you're in on it, right? You know them. They got to you. They're going to use you to get to me. It's contaminated, right? So building rapport is really important. Establishing the trusting relationship, making sure that you're supportive, that your communication is direct, using trying not to ramble, right? Using really direct communication with them so that they can focus in on what you're trying to say. Okay, so psychiatrist reviews or evaluates RB by conducting a mental status exam, orders antipsychotic meds, and close monitoring in the inpatient setting. Um, so you guys can do 8 on your own. We're going to skip 9. Psychosocial treatments. So what are some things that we do to help treat schizophrenia? Besides medicines? Therapy. What kind of therapy? Group therapy. Yep. Super helpful. Who else might need therapy? Mm-hmm. Mm-hmm. Having somebody that you love experience this disease, I can only imagine how just overwhelming it would be. Yes, stress management would be huge because that can be a trigger, right? Mm-hmm. Yep, couple therapy. Case management might be pulled in, right? To try to give them resources. Right. So there's a guy, I can't remember if it's Instagram or TikTok or YouTube, or he's on social media somewhere. He's schizophrenic, and he would video himself with his phone, and then he would watch it back because he was hallucinating, but he wanted, is it TikTok? Yeah, he would hallucinate, but he wanted to like check himself. And so he would video himself and watch the video again and realize that he was actually hallucinating, that it wasn't real. And that's how he dealt with his hallucinations, which I thought was brilliant. Um, and a way to use modern technology for the good, um, which is super cool. So, all sorts of creative ways to help patients deal with this. We'll skip 11. We'll skip 12. Okay. Dipex is my favorite. It works really well. Okay. Whoop. Hold on. I want to do this one. Okay. There we go. As you go in to give RB his medication, he speaks to you in a hushed tone. Is that a bird? Before you can say anything, he asks, do you see the bird over my bed? She's telling me not to leave this room. If I move, she will swoop down and try to peck out my eyes. Be careful. Hello. Okay, I'm going to read the question to you so we can stay on this little blip so you can answer the question. Is he experiencing a delusion or a hallucination? Yes, hallucination, right? Because he's experiencing this with his senses. He sees the bird. She's talking to him. At least he's warning you, which I think is nice. Delusions are false beliefs, so they're thoughts in your head. So they are out to get me. They're watching me. They've poisoned the food. Hallucinations are I see a bird. There's spiders crawling on the walls. I feel um, worms under my skin. I hear music. I hear screaming. Um, you can experience it with your five senses. Is a hallucination. Okay, correct. Identify the appropriate nursing response you would state to RB. Select all that apply. So let me go here. So which of these is correct? So this is tricky, okay? Um, because you have to be careful how you talk to them. So you don't dismiss what they say, but you also don't want to feed into the delusion, okay? So B's a good one, right? Tell me more. It's like the go-to therapeutic communication answer, right? When in doubt, tell me more. So we like E. I don't see a bird over your head. I can understand how that would be upsetting to you. Yes. So you were acknowledging the hallucination. You were saying that you don't see the hallucination. So you are reality checking him, but you are connecting with him that you could understand that it would be upsetting. So that's like the gold standard answer. So you're acknowledging, you're reality checking, and you're also acknowledging the fact that it could be scary or upsetting. Okay. They also have D as a correct answer. Do you guys agree with that? Because what is that doing for him? You're reorienting him, right? Yes, he's safe. You're helping him realize that he's in a safe environment, that it is correct, that it is that his disease process that's causing him to hear this, but he's in a safe environment. So B, D, and E. B like boy, D like dog, E like elephant. All right, after 2 weeks of inpatient therapy, RB's discharged back to his parents' home. He's enrolled in a day treatment program. He and his parents attend family therapy sessions twice a month. He hopes to move to a halfway house in the community. So, I really like these. I think they do a good job of painting a picture for you. So hopefully that was helpful to you guys. Do make sure you spend some time on the bipolar and schizophrenia content. There's going to be a number of questions on your final exam on it. Um, um, the outline for the final is posted, so make sure you take a look at that. We've got one more module to do next week on uh, seizures and um, meningitis. Kind of an interesting one and really short. So you're welcome. Kind of put that one in at the end. Um, but do look at that final exam outline. You are going to have questions going back to the very beginning. So brush up on things like acid-base imbalance and all of the labs associated with that. Remember all of the priorities with ACS. Go back and review the patient education for heart failure. Um, and all of the exam 2 stuff is probably pretty fresh in your mind, but it would be a good idea to do a little once over. Yes, the ATI fundamentals question or exam. So you've got the two practice fundamentals that you've done or you're about to do. I guess the other one is the other one due this week? It's due soon. Um, yeah, so you can go back and do remediation on those two ATI practice fundamental things, and it will review the topics that you personally scored bad on. Very similar, yes. And it will help you brush up on that, okay? There's also 2 additional practice ATI fundamentals exams in ATI that are not for a grade, but they're just extra. So I would do those too because that it's going to be very similar in content. There's a fundamentals book. If you really love to read and you want to glance through the fundamentals book, you can. But I really would just do those practice assessments and then go back and do those remediations. And that should set you up pretty well. And you can see in ATI what the scoring levels are, and you can see how you're doing on these practice assessments. If you're scoring like a 90, you're probably pretty good. If you're scoring in the 50s, you need to do a little extra work. Okay, it will kind of tell you what the breakdown is and what the grade associated with each level is between ATI and the syllabus. Okay. Yeah, we will do a final exam review. We'll probably do it the week before the final, probably later in the week. So I'll get that out to you guys soon. And if I can help, let me know. Otherwise, y'all have a great evening. Yeah, what's up, Carrot?
Quick question. So, just to better understand the grading for this, let's say I made an 80 on the practice exam. Is that my grade that gets put recorded for class
No, it's broken down by like a level. So you get like level 1, 2, 3, or 4, I think is how it works.
for the
And
practice?
depending on, oh, for the practice, it's completion. If you just do it, then you get 100.
Oh, okay.
Yeah, the practices are completion. But the final is going to be that the leveled grade. So depending on what level in ATI you get, that will correlate to what grade you get.
Okay.
So like it's like an 85 or above, you get 100, and it kind of breaks down from there.
And you like if we're just going over just the fundamentals in the practice questions as like on ATI, we like when I open it up, I'm back and forth with going just fundamentals and the theory, the med search stuff because I'm not sure if it'll have some of the med search stuff up there.
It will not have med surg stuff. Your ATI final is just over fundamentals.
Okay, thank you.
Yes, your final is going to be comprehensive, and if you want to do some of those reviews that we have in there, You can do those that are like topic specific. But your ATI final will only be over fundamentals. It will not have any med surg content. I know there's been a little confusion about that, so. Everybody good? You're welcome. All right, y'all take care.